Ready?
Okay. So first of all, everybody, welcome to Boulder County Town Hall with our Executive Director finalist, Danica Lee. Just as a heads up and just some information behind the scenes, we've received over 50 questions from staff to be asked. We will be asking 11 today with the possibility of 3 more based on time. So we have 11 based, but if we have some extra time, we'll have 3 more that we can ask. The questions will focus on leadership, community engagement, public health workforce, evidence-based data science considerations, health equity, and workplace culture expectations. To keep on track, we suggest pacing responses at 3 to 5 minutes per question, and we've provided a copy for the candidates who are viewing. And Amanda back there and Dahlia will be giving some cues as we get to the 5 minutes just to help you. I will ask some questions and then staff in the audience will ask. When you do ask, please remember to introduce yourself, use your pronouns, and identify your title, which I forgot to do. For those of you who do not know me, I am Catherine Palmer. I use she, her pronouns, and I am the Director of Admin and Finance here at Boulder County Public Health. Okay. So a few reminders before we get started. We are conducting a hybrid town hall, so please be mindful of the camera if you're walking across. One thing to know, if you have ever watched a Board of Health meeting virtually, the mic is insanely hot. Meaning that if you're having any side conversations or you're opening a wrapper or you're in your bag, they will hear everything. So just be very mindful so that they can hear the candidate when they're answering questions. If you do have anything, just please exit into the hallway. If you have not been in this building before, which I think everybody has been, outside, just to the left are the bathroom and water fountains, and there are also refreshments up there. We will do a 15-minute break between candidates. And then the biggest thing, the most important thing, in line with our values, please set aside, well, actually, please recognize when you came into this room today, if you already had implicit bias. And if you did, please set those aside. And please listen openly and with intent to what our candidate has to share with us today. After today's town hall, you will receive a link to complete a feedback form. And with that, we'll go ahead and get started.
Awesome. Thank you.
Okay, so Danica, if you could please introduce yourself and briefly tell us about what motivated you to apply for this role.
Yeah, absolutely. Good morning, everybody. I'm so excited to be here. And it feels a little bit weird to me to sit when I'm speaking to a big group like this, but I'm going to try to play nice for the camera here and everybody online. I am just so excited to get this far in the process. I know you have a really tough decision to make. My pronouns are she, her, they, them. I've been with the Denver Department of Public Health and Environment for 21 years. I started off in an entry-level capacity in the food safety program there. And then have had lots of great opportunities over the years. My current role is I'm a director of one of the divisions with the Denver Department of Public Health and Environment. So I am the director over the Public Health Investigations Division, which is a number of regulatory and compliance programs, epidemiology, and disease intervention. And can you read the question for me again? I can make sure I got everything there.
Yeah, can you briefly tell us what motivated you to apply for this role?
Yeah, absolutely. So obviously I'm a career public health practitioner. You will see that I don't have advanced degrees. I don't have a master's or a doctorate. That's not normally something I would call out proactively, but I think it's an important piece of my response to this question. When I started with Denver, I actually applied for a position that had some cryptic government name. I didn't even know what I was applying for. There wasn't great information about what the program was. But when I joined and started working in the public health realm, environmental health, it quickly spoke to all my passions to be able to serve people, serve my community. As I've advanced through leadership positions, serving my team as well, is I find really exciting and fulfilling. And I also lived in Boulder for 10 years. I visit here almost every weekend because my parents still live here, but I've lived in Superior, right where the fire was, in Lafayette, and a number of places of South Boulder. And my first 10 years in the state was in Boulder and running the trails here and volunteering in the animal shelter I was talking about. So for me, this was a really exciting opportunity to come up. I love working in the leadership realm. I love supporting a team and engaging a team. And then, of course, I love public health work and Boulder as well. So it seemed like a great fit.
Thank you. So as you can tell, the vast majority of public staff have been working hybrid or fully remote since March 2020 at the start of the pandemic, which is still even how we're conducting the town hall here. What are your sentiments regarding remote and hybrid work environments?
Yeah, so I think going through the pandemic, it made us all realize that we could be disrupted with how we normally do work and still be really productive and effective. And the work-life balance component that has come out of it. I mean, while we were all in the thick of COVID, I don't think anybody would have used work-life balance as a term that applied in that situation, but hopefully we've all kind of, are in a less frenzied state right now and have more time. But yeah, having the ability to work remotely, I know for my team has really been a game changer in terms of offering more opportunities for work-life balance, more flexibility, especially people who have kids in their lives or pets or whatnot. Really a game changer to be able to manage your schedule and your work and your location in a way that's really different than we ever, I think, typically had access to in a degree to which we never have before. So I think just for the work-life balance, it's amazing. There's also accessibility issues that I feel like we've, have now that we didn't. And I know there's kind of two sides to that coin in terms of the public's accessibility through remote platforms. Not everybody has access to devices and resources to do that. But I would imagine for most of us as employees with a local public health agency, it offers different accessibility options, So if I have a sick kiddo at home, I can work part of the day and take part of the day off to care for my child. And so, yeah, I think for all of those reasons, it's been really important to me, the agency I'm currently with, that we don't toss all of that out. In Denver, we did have a mandatory return to work 3 days a week that the mayor implemented. And going through that change was pretty tough for everybody, but still having that flexibility. We have much more flexibility than we did before the pandemic.
I'm going to ask you a follow-up to that one. So what role do you think the physical office should now play in the workday?
Yeah, that's a great question. And, I think it depends on the team. I think it depends on the nature of the work. It depends on, the degree to which people already have good working relationships. But I do have to say that being fully remote for a lot of our team during the pandemic, we had so many new people come, and it was not a barrier to building a team environment that we were working remotely. So I think, I do think every once in a while there's meetings that it's important to try to come together for and try to connect for. Also to come together just for celebrations and in-person activities may be optional. But yeah, I think a lot of it also comes down to what the specific needs are of the team and the work that's being conducted.
As the executive director, Danica, you will need to make a difficult and unpopular decisions at times. Can you tell us about a time you made a decision as a leader that was unpopular with staff? And when answering this question, please identify, what did you consider in your decision? Did you make any mistakes? And if so, what did you learn? And how did you engage and stay connected with staff?
Yeah, good question. So I think I'm going to use another COVID example, which I feel COVID gets all the attention right now, right? But so many good examples from the last couple of years too. So during early COVID response in Denver, I was the deputy public health official working in partnership with our executive director, Bob McDonald, who's the public health official. So I was supporting him in a deputy role with the COVID response. And we got to the point pretty quickly, like I think most LPHAs did, where we needed to get some boots out the ground going into the community to investigate outbreaks, to provide consultative support to different settings. And this was a really tough one. I mean, this was terrifying. It was a terrifying time. There was so much that we didn't know. And I had to make the decision based on the business needs of assigning work for in-person duties both visits to jails, visits to shelters for people experiencing homelessness, and actually enforcement activities. We had a pretty significant enforcement effort with our public health order, our broad public health order, our stay-at-home order in Denver. And so, yes, this was tough because it wasn't, most people were not jumping into this work or excited to go do this work. And so what I considered in making that decision was really the business needs. I think, we all didn't have much choice there. We had to find a way to get this work done. Did I make any mistakes? I'm sure I made mistakes. I make mistakes regularly. I think like all of us do. I try not to make the same mistake a bunch. And I think that thinking back to the challenges there, just the frantic pace of work, it was impossible not to drop some balls, to keep everything in the air. I'm trying to think of a specific mistake. Looking back now, there are convenings that I would lean in more. There were tough conversations with some of our partners around, especially like in the space of homelessness, where I, looking back, would have tried to be there, hands-on. I was hands-on for a lot of it, but just a few things where staff members were left with really heavy, tough conversations to have. And so trying to be there for them during those times is always a priority for me. How did I engage and stay connected with staff? So whenever I'm going to ask my team to do something that is not necessarily the funnest assignment, or maybe it's something we've never done before, maybe there's safety considerations, for me, it's really important that I do that work with them first. And so, the first visits to our jails in Denver, I was participating in those. We stood up a really large congregate shelter for people experiencing homelessness, actually two of them at the National Western Center and the Denver Coliseum. And I was out there, consulting on the setup and the arrangement and whatnot. So being there and also proactively soliciting people's concerns and uncertainties, and then stepping into a space to talk about those proactively, especially when it comes to safety. I think all those things are really important. Another thing that I do, and I know I need to move on to the next question here, in terms of engaging with staff, is just checking in with people, making sure that folks have lots of different ways that they can speak to me, whether it's getting together for a coffee or me stopping by their workspace if they're in the office to say hi. Just getting to know people on some type of personal level, I think is very important to developing a sense of trust with your leader.
Thank you. Okay, this one's a little bit longer, so bear with me. In public health, our mission and vision strongly center on health equity and promoting our staff encompass and represent this through a variety of approaches. We understand each person is in a different part of their journey, and we respect and support this. We are also aware that sometimes staff can initially be hesitant to participate, continuously abstain from some of this work, or be avoidant of committed growth. What do you see within your role as the executive director to address this?
So let me say that the work that I do now centers strongly around health equity, and I think this is true of a lot of us in public health. The last couple of years, I've been really fortunate to work at an organization that values race and social justice, and has provided a lot of foundational training and tools to the entire staff. And I think, some level of training, I mean, you mentioned implicit bias, that's kind of a surface level example when you're talking about equity and race and social justice. But it's important to be having conversations and for a leader to be visibly involved on these issues. I'll talk about some of what has worked for me and been successful in my current role. So I think using an equity lens to inform our work and a race and social justice lens as well, for me has had a really transformative impact where it brings new meaning and new opportunities to our work. We're not just, conducting inspections and generating a certain number of inspections or whatever kind of the output looks like. It's really important that we use everybody's eyes and ears to understand where we have structural inequities that are perpetuating different health outcomes and disparities in health outcomes. And also trying to understand where our work can impact social determinants of health. And so in Denver, I was really fortunate to be one of the first cohorts of city leaders to go through a race and social justice training with the Government Alliance for Race and Equity, which is a really wonderful national level organization that does a lot of consultative work supporting government agencies. And since then, I've had a really engaged, passionate team in this area as well. And so I am I always participate, well, I don't always because sometimes schedules conflict, but I stood up with a number of members of my team, our own equity group, in like an equity committee, I should say, for our team. And so we meet every month, and a number of activities that we've done is we come up with racial equity action plans for the year. So as we're conducting our work planning for the year, that aligns up with our strategic plan, really trying to identify actionable measures that we can do to be more culturally responsive or try to address those systems levels issues that perpetuate disparities that we see. So having these conversations, not everybody has to be part of the conversation. They have to hear the conversation though. And within my organization, having some foundational level of training has been critically important so that we all at least have a foundational awareness of certain, kind of the framework that we're operating in and an understanding of structural inequities. And then also really focusing intentionally on an inclusive work culture as well.
All right, so moving on to question 4. Over the last decade, public health has played an interesting role in responding to emergencies such as floods, fires, and the pandemic, as was also shared with us. What do you see as the roles and responsibilities of the executive director when public health emergencies arise?
Yeah, absolutely. So public health emergencies, and y'all have had some really big ones here. I mean, we all have, but especially the fire, I can't even imagine that response must have rivaled going through those intense times in COVID. And anytime we have to stand up an operations center for an emergency response, there is a lot of anxiety that comes with that. It's an uncertain situation. People don't know what they're going to have to be dealing with, what work they're going to be assigned in some cases. And also working in that incident command structure, like many of us do during an emergency response, is a little different than how we're operating during day-to-day kind of programmatic approaches and strategies. So I do think it's really important for the executive director to understand where the anxieties and concerns of the team are, to be responsive to them, to step into the space, roll up, if I were in this role, it would be important to me to roll up my sleeves, especially when standing something up, so that I'm not just sitting in an office or behind a desk or behind a computer screen, but that I can help, figure things out, while also respecting the skills and expertise and the autonomy of the awesome staff that I know you all have here. And then, once we're in incident command system, I'm sure you have a number of assignments, or your executive director may be assigned a certain role. In Denver's response, I step in overseeing in a leadership role, the entire operations center. That's our incident command center for our department. And it's because you're making a lot of really rapid changes and people are operating in spaces that they're not necessarily always operating in. It's important to have somebody who can kind of lean in and course adjust and help course adjust. So being a leader that can listen to the staff about where those course adjustments need to happen, where we have gaps, all of that in my experience is an important role for an executive director for an emergency response.
Great, thank you. Okay, so this next question has 2 parts. I will ask the first and seek your response before I ask the second. We have a varied set of public health partners ranging across the political and spiritual belief spectrums. During the pandemic, some of our important partners had opposing views from public health and wanted to discontinue mitigation practices with their organizations. What has been your strategy to encourage partners to continue working with public health and reconsider mitigation activities?
Yeah, this brings back memories, thinking back to a response for this question. So just like here, I'm sure, we dealt with a hugely polarized community over mitigation controls, just conspiracies about COVID, the efficacy of vaccines, and like you all, I'm sure, heard about it a lot. Some of our staff and those of us throughout the organization also had scary situations with people making threats, really angry people, and yeah, all of those situations. I think you have to kind of experience other people's belief systems and come up against those. With my particular organization, we took a little bit more of an enforcement-oriented approach, which we were able to do because of some of the authorities that we had. So we used a combination of like proactive meetings with various groups, and I'll talk about those in a minute, and actually going out and doing some enforcement where we needed to do that, where we had players that were not adhering to requirements, for example, of our stay-at-home order. And I think it is important in a lot of situations to have both of those things, the proactive efforts to engage and communicate and bring stakeholders into conversations, and then some of the kind of farther downstream consequences that might be there where there's an enforcement consequence. With the groups, with my role, I was very involved in meeting with lots of different stakeholder groups during COVID response. And it's amazing how having somebody who will actually engage in a conversation and just be there to show up and have the conversation sometimes can go a really long way with partners in terms of advancing change. And so one group that I engaged very closely with was our Department of Safety. And especially we had a vaccination requirement in Denver starting in August of 21. And all of our city employees, all of the city contracted staff, anybody operating under a city contract, all of these folks had to be vaccinated for COVID. And so these questions and these issues really came to a head in some very dramatic ways, including litigation. But again, having conversations, and with the example with Department of Safety and the sheriff's staff, there were a lot of folks who were not excited to get to be vaccinated. And there was, of course, an exemption process and making sure that we were being transparent about the why behind things, but also kind of, what people's options were for an exemption. All of that was really important to supporting our efforts. So let me just see if I think that was just the first part. So let me end there.
Yeah. So then the second part, going back to that employee engagement, in these types of situations, how did you support your staff in working with partners whose views and beliefs may run counter to effective public health practices?
Yeah. So a couple things come to mind. I mean, certainly entrusting staff to make decisions about their own safety based on their own situational awareness is incredibly important, especially when you're going out into the community. And so one thing that I always tell my team is that if you feel unsafe and you're not even sure why, make sure relocate yourself and get out of there. Now, I know that's becomes a different conversation when we talk about safety, against a virus that is kind of out in the environment. But generally speaking, that's really important. And I would still support that message, even for, if people didn't feel that they had the PPE they needed when they went into a facility. I would empower them to remove themselves from that situation. And then, focusing on professionalism, on trauma responsive communication, I think is very important. Having some basic skills and training on trauma responsive, like communication and strategies and de-escalation and meeting people where they're at. And, really focusing on just professionalism and the expectations as an employee of the government that you have. You're not there. Everybody has opinions, right? But we're not there at work operating in a space where we're espousing our opinions or even kind of engaging in a lot of discussion. But you do still have to hear everybody else's opinions. Also thinking about resiliency. Doing this work is really tough. It's really draining. I find people in public health are some of the most passionate people, but it comes at a price, right? I mean, we put so much of ourselves into our work. It can be very draining. And so focusing on resiliency, whether it is, group sessions to talk through pain points or challenges or behavioral health resources that are available to all of us, finding opportunities to celebrate things. All of those things I think are foundational to supporting everybody's day-to-day interactions with people who may have very different opinions from against the work that we do in some cases.
So we'll transition now out to the audience. So whoever has question numbers. We have 6. Don't forget to introduce your pronouns and your
Hello, I'm Dalia Mohammed, and I'm the Administrative Specialist of the Strategic Initiatives Branch. Question 6 is, what is the most difficult but accurate feedback you've received at work? How did you respond and what happened as a result?
Okay, oh man. The most difficult but accurate feedback I've received at work. I came into a supervisor role as, I guess, a relatively, young person. And there were definitely some things I needed to learn pretty quickly in terms of how to engage, particularly with people who used to be peers. And so some of the feedback that I received was about how I was providing feedback. And it made me realize, because I was using just kind of a standardized approach to providing people feedback on their reports. I would review different types of inspection reports, had to manage some level of consistency for legal purposes. And in my mind, I was like, oh, well, I'll just send everybody an email every week with little list of bulleted items from their paperwork that needs to be addressed. And this did not work for everybody. It didn't work for a lot of people. People have different preferences for how they want to receive feedback. I think at the time too, I was not in the best calibrated space for really understanding what feedback is critical and where can somebody have their own type of approach. And so that's something that I have really focused on is, yes, there's some areas where we do have to be standardized and follow very specific procedures, but there's lots of areas we don't. And there's lots of opportunities to have our own style. And so, yeah, those early lessons, I think, with how I was providing feedback translated into a much greater awareness about the need to customize the approach for each individual employee that you supervise. And then also for me to make sure that, the feedback I'm provided is truly necessary and not just kind of an overly managing something.
Number 7.
Amanda Sandoval, Personnel Coordinator, she, her pronouns. We strive to support and hold a diverse workplace, and there are many indicators that may represent disability or lack of racial, cultural, or identity diversity. For example, once hired on, public health does not currently track ongoing diversity goals to monitor if we are visibly doing the right thing by our employees to address equity issues. From what you know about Boulder County and this public health department you may lead, can you verbalize a measurable time-bound goal for workplace equity in our department?
Yeah, sure thing. I'm going to start with an example that's pretty surface level, but very important, I think, which is the racial and ethnic diversity of the team. And so actually within my division that I run, we have goals to increase our the number of people who identify other than white who are being hired, and then our overall composition of the team as well. And so, yeah, just having some really clear goals and strategies as well. Within my team, we've done a lot of kind of experimenting with different recruitment strategies, different ways of accessing different candidate pools, and even just increasing the overall awareness of public health careers has been very important. I think also, this is when we talk about goal setting and particularly with equity, it's not the person who's sitting at the top that is important for determining what the content of those goals is. Yes, the leader plays a role in, in having those conversations, but the ideas and input and thoughts of everybody on how to make a work culture more inclusive are super important, I believe. And then also giving staff the empowering people to come up with new ideas and implement changes and fail and sometimes not be successful is really important. And in this equity space, whether we're talking about more structural factors, like complaint-based systems and the impact that they have on who has access to them, or whether we're looking at kind of culturally responsive materials or team inclusivity, really critical that it's not a leader's ideas. It's how a leader brings everybody else's ideas and helps make space and bring them forward.
Okay, number 8.
My name's Penny. I'm the VFC nursing supervisor in immunizations. I use she, her pronouns. This question has 2 parts. I will ask both. Please answer each separately. I can go back to re-ask if needed. How do you define community? What do you see as the public health department's role with priority populations in building community?
Yeah, that's a good question. So I guess how I would define community is all the parts that make up a whole in terms of people and populations, and recognizing those distinct populations that wouldn't necessarily play out in large, significant numbers. So, for example, in Denver, we have a very small population of Indigenous Americans, but it's important to have an intentional focus on health impacts to all groups. In thinking about so community, I would say, yes, it's comprised of the entire population, but an awareness of how we all kind of, the different categories of populations. And then thinking about the word community also evokes, in my mind, a lot of thoughts about how we're interconnected and how we leverage our interconnectedness. Whether we're talking about connections within a staff, the community of a staff, or connections with the broader community. And so making sure that there are a lot of intentional opportunities to reach out to different parts of the population, to evaluate what impacts and input folks in different populations have, and then considering those and working to address those things, I think is incredibly important. Could I trouble you to read the question again, the first part, to make sure
The first part was how do you define community?
Mhm.
The second part is what do you see as the public health department's role with priority populations in building community?
Okay. So yeah, I think the local public health agencies' roles, we're looking at social determinants of health. We're looking at what are the factors and what are the structural inequities, the structural characteristics that are sometimes compounding or perpetuating some of those different health outcomes. I think it's hugely exciting and engaging to think about how we can make changes to a system to elevate the health of a particular population. That's what we're all here to do. That's what we're all about, right? But yeah, I think, being intentional, having great partnerships with, because as a health agency, we can't do it all. We have to leverage the relationships of partners with their own expertise in order to kind of optimize our effort and outcomes.
Number 10.
I think mine is 9.
Oh, 9.
Yeah.
Hello, my name is Carla and I work for the Communicable Disease Division. I'm the support and my pronouns are she, her, hers. Question number 9. As the executive director, where do you see your role in championing and progressing social justice movements such as police brutality, anti-trans legislation, reproductive rights, and climate change?
That's a tricky one, isn't it? As we all have had to deal with the world of politics, and be mindful of kind of who we report up to. And I do think that it's important to understand the politics within an organization because it's very important to how we advance change. The role of local public health agencies with reproductive rights, with, including everybody, including, transgender, LGBTQ. I love the fact that you all have some programs here that are dedicated towards a lot of this already. So I think within the context of the political climate, that has to inform how we do the work that we do. But anytime we're talking about improving the health outcomes of women or children or any population, I think there is a role for public health. And I also think it's strategic to bring in staff to for everybody to be involved in the conversations about the work that we do take on in these spaces, the priorities that we identify together, and then hopefully advancing a harmonious dialogue with kind of those political leaders and factors that sometimes can end up impacting us more than we want.
Hello, my name is Janice Stiglich. I use ella, they pronouns, and I am the principal investigator for the A La Raíz project under community health. So, have you ever received feedback from a subordinate or peer when your behavior caused harm? Provide an example and how you responded.
When my behavior caused harm, I'm sure I have. Just need to think here for a minute of a good example. Yeah, so that's a great question, by the way. I like to really focus on a positive work culture, a fun work culture, but also accountable one. And I have received feedback in the past sometimes that maybe I'm focused too much on being positive. And not enough on really trying to like hone in and address pain points. And so I have thought about that a lot. I do think, having energy, having passion for what we do, being excited to come to work every day and enjoying the people you work with. I think all of that's really important for an engaged staff and kind of an optimally functioning organization. But I do try to make sure now, after receiving that feedback, I'm more mindful about where I might have some blind spots, where I need to be kind of proactive in addressing pain points that exist. And so that's something, exactly that is what I try to do. When I'm sensing or hearing that there's a pain point or a concern, I try to connect with people directly and have a conversation about that and really understand if they can identify any solutions or how I might bring together, our team to identify solutions.
Okay, 11.
My name is Jordan Bullard. I'm the Site Projects and Vital Records Program Manager with the Admin and Finance Division. I use he, him, his pronouns. Here's the question. What is your method to bridge the requirements of government and leadership with staff centered in the community and grassroots organizations? Please provide an example of a time you've done this.
Can you read it again, please?
Definitely. What is your method to bridge the requirements of government and leadership with staff centered in the community and grassroots organizations? Please provide an example of a time you have done this.
Yeah, sure thing. So let me go to a non-COVID example, because COVID's what comes to mind first, but I'm going to try to focus on a different example. So in my role with the division I oversee, we enforce Denver's noise ordinance, which isn't necessarily the first thing that comes to mind when you think about public health or environmental health. But we very much use a framework of like noise contributing to psychological distress and discomfort. And so our health department team enforces the noise ordinance. And a number of years ago, there is an effort that's just being finished up right now to rebuild I-70 going through Denver. And this became such a flashpoint for the community that was in this area that was being redeveloped. So I-70 is, as you know, goes through North Denver in one of the most polluted zip codes in the country. And also an area where there was a lot of kind of historical, there was like smelting operations and all types of environmental factors that impacted social determinants of health. And that community in Globeville, Swansea is also a very Latinx, a large Latinx population. And so, you know, environmental justice concerns have been huge in this area. So when the developer went to work on the project, they actually had to get a variance to our noise ordinance. So they had to go before a Board of Public Health and Environment and seek a variance so that they could do nighttime construction. For a number of reasons, when you're doing that type of construction, it's much safer to do it at night. And so there were hearings before the Board of Public Health and Environment. There was actually one every year for 5 years. And we just got through the last one. But the very first one for me was a education on community engagement, which was not something that we had done well before this first variance. And I certainly took a lot of heat for that, but my team out engaged in these communities also took a lot of heat and were a huge part of informing how we do it better for future years. And so, you know, worked with our Office of Social Equity and Innovation in the City and County of Denver that manages that race and social justice initiative and training program that the city has, and really focused on how we can be proactive about engaging the community, but then also, you know, helping our staff understand how they can better facilitate conversations with people in the community who have input, the importance of being responsive. And then also, I mentioned this before, about leveraging the partnerships of community organizations. So really important for us to hold spaces and have meetings where we're inviting not just the public, but partner organizations. Particularly, there's a number of them for that part of you know, North Denver, that became, as we went, we got kind of better and better at this, I think, each year that we went through the process. But by the time we were going through the last few rounds, we actually were getting almost across the board positive feedback from community members and community organizations, and from our staff who were involved in this work. And that was really different. That was a 180 from how things started out.
Okay, optional question 1.
Very good. Hi, Monica. My name's Elia Barraza. I use she, her, ella pronouns, and I am the Generations Program Manager, program under Community Health. What do you see as the public health role with displaced or disproportionately impacted populations who do not typically seek out government services or support?
So these tend to be the people who need our help the most. In Denver, we have stood up a migrant sheltering operation, as you may have heard about, over the last 6 months. And I was really fortunate to have the opportunity to play a big role in the health department's support of that. But, you know, just thinking about where we tend to see the most health disparities and where we have the most work to do to give everybody access to the best health and well-being, focusing on, you know, people of undocumented status, people who've been historically marginalized. There are special considerations for those types of populations. You really can't take an across-the-board approach in supporting, you know, thinking that programs that support the majority of your population are going to support people who need it most. So I do see it very much as the role of a local public health agency to help improve health outcomes for those populations that are underrepresented and historically marginalized. And, you know, again, you can kind of butt up against politics and opinions of folks like county commissioners and whatnot. So, it can definitely be challenging, but I think our role is clear in terms of, we need to uplift those people who need our support the most.
Right. Hi, good morning. My name is Jax Gonzalez. I use they, them pronouns. I'm the program manager for OASIS, which is our LGBTQ youth program, housed in community health. So as the signs of the pandemic demonstrated, what will you do to deliver sound principles in the face of misinformation?
Yeah, this is tough, especially when it seems like there are no facts that we can all agree are facts anymore. There's always going to be dissenting noise and different opinions. It's important to not block those out, but at the same time, keep a healthy perspective about them. And we have so many experts, especially in Colorado, we have so many experts in the field of public health and, immunizations. And we have a really rich and robust landscape in this state. And I think that gives us some opportunities that maybe are more difficult to come by. And Boulder in particular, I mean, the landscape of community organizations here is really tremendous and exciting. And the work that your program does, I think, from what I know of it, seems really exciting. Could I have you read the question one more time? I want to make sure I'm remembering all of it.
Yeah, as the signs of the pandemic demonstrated, what will you do to deliver sound principles in the face of misinformation?
Yeah. So a lot of this comes down, I think, to messaging and we all dealt with this where, we would be surprised by the state health department, what they came out with during COVID or what the CDC says. And so striving for alignment to the greatest degree possible, which is not always easy to do, I think is important. But then also having your kind of somebody who is the voice of expertise. In Denver, this was Bob McDonald, our executive director. He was the one that was out there all the time, kind of messaging and pointing to the data. We realized really quickly, like everybody did, the importance of standing up dashboards, having real-time publicly accessible information about deaths, about illnesses. This was important, especially early on. So figuring out where those key metrics are and trying to take as much opinion and debate, make them as starkly kind of fact as you can, and being consistent and pointing to those same metrics and using those same strategies for messaging to folks, I think is important. And then, we have the School of Public Health here. We've got a number of amazing universities with environmental health and public health programs. So there's a lot of opportunities to partner too, I think, when we do have questions that we're trying to answer. I was fortunate to work with some folks at the Public Health Institute at Denver Health in evaluating contaminants with cannabis. When we kind of worked earlier in the process with cannabis legalization, because this was an area where there's a lot of mixed messaging. And so we actually designed a study and took samples of products from shelves and had them analyzed in labs so that we could understand really, truly what the rate of microbial and pesticide contamination was. So, even kind of special projects like that, I think, can help inform new expertise and build more trust with the community.
I think we have time for our last question, which is.
Hello, I'm Keith Rawls. I'm the immunization program coordinator. I use pronouns he and his. What 2 or 3 challenges do you envision for impacting public health in the next 1 to 5 years?
Yeah, great question. Behavioral health, I think, is easily one of the biggest areas, and I know a huge focus of the roadmap here that you all have in Boulder County. And then I think we're having an increasing recognition about the role firearms play in our public health outcomes across our population. So yeah, those two areas in particular behavioral health, including substance use, I would kind of categorize under there. And yeah, poor outcomes from firearms, but homelessness is also right up there. And I don't know, I'd be hard pressed to figure out what that hierarchy of 1, 2, 3 is, because that's another one that is, you know, such an interconnected, challenging issue that we're all facing.
All right, great, thank you. Well, that wraps up all the questions that we had. Like I shared with you all, we will share out a form at the end after all of them. But if we want to, we can move out into the lobby. We have a little bit of time, so if you want to just ask Danica some questions, learn a little bit more about her, feel free to do so.
Thank you so much, Catherine. I want to say thank you all so much. I'm so excited about this opportunity. I'm really excited about the idea of leading your amazing work here. Y'all have a wonderful reputation, and I've thought the world of the work here at Boulder County Public Health for quite some time. So thank you for having me today.
Ready,
We are
Delia?
so on top of the current.
Okay. So you guys like me and you're gonna sit with me again. Okay. So I am Catherine Palmer. I am the Director of Admin and Finance. I use she, her pronouns. I want to welcome you again to the Boulder County Town Hall with our Executive Director Finalist Lexi Nolan. We received, as you all know, 50 questions from staff. We will be asking 11 of them with the possibility of 3 if we have more time. The questions will be focused on leadership, community engagement, public health workforce, evidence-based data science considerations, health equity, and workplace culture expectations. To keep on track, we suggest pacing responses at 3 to 5 minutes per question, and we have provided a copy to you for easy viewing. Amanda will also be tracking, so she will show you a cue card if you're getting close on the 5 minutes. Perfect. I will ask some questions and then staff in the audience will ask. This is a reminder. Please remember to introduce yourself, identify your pronouns and your title. And then a few reminders before we get started. We are conducting a hybrid town hall. So up above, we'll have plenty of staff that are also viewing in. Just a gentle reminder to everyone, the mic is still hot and it will pick up on any noises or any extra side chatter. We will do a 15-minute break between candidates. And then most importantly, in line with our values, please recognize if you came in with any implicit bias. And if you did, please check that at the door, listen openly and with intent to what our candidate has to share with us today. Okay, so with that, Lexi, can you please introduce yourself and briefly tell us about what motivated you to apply for this role?
Sure. So, hello, everyone. I'm Lexi Nolan. I use she, her pronouns. I am originally from Texas, the Lone Star State, which can often invoke fear in people. But I will tell you that part of my experience growing up in Texas was really to see from a bird's eye view what racism, discrimination, exclusion created in a society, and the ways that the government can either be on the side of the people or not. You know, when people say, I don't trust government, I know what they're talking about because I grew up in that kind of a community where there was a good reason not to. And as an ethics student, which I spent a lot of my college and graduate school years studying ethics, you know, you learned all the horrific ways that government has abused communities, and particularly communities of color, and created oppressive systems. And I have always personally had a real interest and commitment to social justice, and in my professional work that manifests as health justice. And so I really began retraining. I was in a graduate program focused on bioethics, which was teaching me basically how to moderate relationships between doctors and nurses or doctors and patients. And I said, this is not what I want to spend my time thinking about and doing with my life. And so I really changed the trajectory of my graduate school studies to focus on social justice with a focus in health equity. And at the time, back in the mid-90s, there were not a lot of spaces in the United States where you could have those conversations. And so what I ended up doing was really gravitating towards thinking about health equity by working with international organizations. And when I was ABD, so I had done everything but my dissertation, I started working with Pan American Health Organization in Washington, and I set up their health equity platform for them, and I published a few books with them and just really tried to kind of get in the mindset. And that exposed me to a group of people working internationally that were very focused on health equity and had a lot of expertise that I had never had access to in the United States in that space. And really centering justice in that conversation, understanding a social justice grounding in health equity. And that is when I feel like my adult brain really started to form. That was when I feel like I started really understanding what my work was in the world. And it took me down a path that allowed me to work with a pretty wide-ranging variety of organizations. So after I worked with the Pan American Health Organization, I coordinated a health justice nonprofit based out of South Africa, focused on health equity. And what we were really trying to do was demonstration projects on how quickly can you advance health equity, either in a local group or in a country, by using principles of combining an evidence base with policy change and community engagement. And that was, I was the only American in the group. I felt very lucky to have been put in that position. But I got to work with ministers of health. I got to work with national leaders in academia. I got to work with folks from WHO, mayors, community health workers, social justice advocates. One of the things that we did was we started a book series called the Global Health Watch, which was a response to WHO's annual report about health, but it took a political economy perspective. It didn't just give you the data. It said, why is this happening in our world? Why are we seeing patterns of poor access to care, of expensive drugs? What is the behind the scenes? Basically, what are the roots that are creating this? And that book is now in its 7th edition. Yesterday was our launch of the 7th edition. And that's the kind of stuff that really gives me juice. And it's part of why I wanted to work in Boulder County, was because I felt like this was a place where all of those experiences and that focus and that intensity of drive to create the world that we're supposed to be living in could kind of come to fruition and manifest in a real community. And that's what excites me about this job.
Thank you. So as you can tell, we are in a hybrid nature right now, even for this town hall. The vast majority of public health staff have been working hybrid or fully remote since March 2020, at the start of the pandemic. What are your sentiments regarding remote and hybrid work environments?
That is a very practical question. Yeah, so I think it's a mixed bag, and I think that it's a space that we have to think carefully about who we want to be as an agency. There are lots of individual benefits from, I love being able to get up and have my pajama bottoms on in a meeting. I'll be honest with you. And at the same time, not everyone in our staff gets to do that. And that is something that we need to think about. There are advantages to being in person with each other. When I look at you and I see you when you're in the flesh, it changes the relationship. I think it's part of like why we are human beings in bodies and not AI brains, right? Being in community with each other sometimes requires us to be in proximity of each other, to build that relationship, to have that ethereal connection with each other, to have the opportunistic conversations of walking down the hall and going, you know what, you said something the other day that caught my ear and I didn't get to follow up with you in the meeting, but this is, hey, let's think about this together. Or I've been trying to figure out how to solve this problem, but you want to go to lunch? You know, those are serendipitous moments that we don't get when we're hybrid, when we don't have, you know, these structured opportunities to connect with each other. And I think we've been thinking a lot about like, what is it that's keeping folks from coming back to the office? And the convenience is one piece. You know, there's also, you know, technical stuff like gas, there's the impact on the environment, all of those good things. But I think that we do have some work to do to think about what is it that makes being in person rewarding for us as staff, for our community as the beneficiaries of our work together. And how do we create some pull factors, right? How do we make it attractive for folks to, you know, take a couple of days a week to get back in the office? What are those things that will make it fun for folks? And, we're not automatons, and the value of our work isn't measured by just punching in and punching out. Or attending a meeting. It is about the quality of the work that we do, and sometimes we need to be able to do it together. And that on top of some of the equity issues that I think we do need to think about, how do we reward people that do have to be here every day? I think are important things for us to be thinking.
So I have a follow-up for that one. Along that same lines, then what do you think the physical office, how do you think the physical office should now play in the workday?
Yeah, so, I think that, there are ways that we can find to make it fun and attractive for people to be physically in community with each other again. We have not, we've had a couple of experiments that I think maybe haven't been entirely successful. We do have a work agreement that asks all supervisors to be in the office a couple of days a week that we haven't really been enforcing. But, there's more than just the value of being in the office than saying you need to be in the office. It's like, why? What are the conditions that make it valuable for people? Because I think when you experience the value of it and not just being told to be in the office, but you experience the lift that it gives you, the connection it gives you, the innovation that it gives you, that's when you internally start to want it. And so, there are psychologists that say, if you're feeling down, you should put a smile on your face and it'll trick your brain into feeling like you're feeling good. And it's like, I don't think we have to go there, but I do think that there's something about sometimes the practice comes before really feeling the reward and feeling the shift. And then I think we should be questioning, do we want to make a commitment to really enforcing that agreement that we were going to be in the office? And what are the things that make it fun that we can really try to be explicit about elevating and creating opportunities for folks?
As the executive director, you need to make difficult and unpopular decisions at times. Can you tell us about a time you made a decision as a leader that was unpopular with staff? When answering this question, please identify what did you consider in your decision? Did you make any mistakes? And if so, what did you learn? And how did you engage and stay connected with staff?
Yeah, that's a great question. So before I answer the specifics on that question, I'll share a little bit about my leadership style, because I think it helps explain how I try to manage the reality that you can't always please everybody all the time. It's not possible, because sometimes folks will have different views of what should be done, and they're mutually exclusive. So I actually subscribe to adaptive leadership philosophies. I believe that there's a big difference between authority and leadership in an agency. I believe that we are stronger when we make decisions together. We have been working over the past year or so to push power down in the agency, to really create a more dynamic decision-making environment in the management team, to restart our supervisory meetings that are also places where we're connecting with staff, where we're getting feedback, where we're getting direction from staff. And I think that that's been helpful. What I really see the value of adaptive leadership is in having a space where people feel comfortable to express what they're thinking, what they're feeling, disagreement, sometimes being comfortable and being uncomfortable, recognizing that there won't be resolution to an issue on a particular day, or that it may not go your way, not taking things personally. Sometimes that's hard for folks. But I think when you create a space where discussions are happening in group and not just at the top, and there's transparency about information and people get to say what they think, then I think when those moments come when an unpopular decision has to be made, that people understand the context, that sometimes they might change their mind, sometimes they might not, and that's okay. But that it depersonalizes, it doesn't feel like an attack on the person. You can, we're gonna make a decision. We're gonna do this, and this is why. And being able to explain the why often is really helpful for folks to be able to say, well, I didn't agree with that, but that's a decision we're gonna move on and we're gonna implement, whatever. That's important. Now, that's a pretty high level idealistic description of the process. And there are, a dozen decisions every day that any one of us in this room make without doing a big consultation that we're just expected to make. There are casual conversations that we have with people, and in the process of a conversation, we make commitments of our teams that we didn't consult with them on necessarily. It's part of our job responsibilities to be able to make those kind of decisions, and it's impossible to consult all the time on everything. I recently asked a team in Boulder County Public Health to step in and help out with something in a space that was a little bit of an unstable space. An event had happened, and the county needed some folks to help out in that space. And I said, let's ask our folks if they can help in that space. And it was not appreciated. I will be very frank about that. It was, I admit I didn't consult. On the other hand, it was a request to ask if they could do it. And I got feedback that it was really not appreciated. And I appreciated the feedback that it was not appreciated. And the first thing that I did was I worked with staff to first of all, to understand what had happened. And then I met with the staff and I said, hey, I'm really sorry. I asked if we could bring you into this space without consulting with you first. It was not comfortable. It was the wrong thing to do. I'm sorry. Let's talk. I would love to hear more from you about kind of what that thought process was for you, what your experience of this event that made you super uncomfortable was, so that I understand better where my limitations are about decision making. And so that I don't repeat it in the future. And, I hope that the staff felt like that was a genuine effort to improve my own practice. But I would say that pattern of, you stop, you try to understand and listen to what the response is, you apologize and repair harm if you can, and you think together about how it should have gone and how it will go in the future is part of my approach to those kinds of missteps in decision making.
In public health, our mission and vision strongly center around health equity and promoting our staff encompass and represent this through a variety of approaches. We understand each person is in a different part of their journey, and we respect and support this. We are also aware that sometimes staff can initially be hesitant to participate, continuously abstain from some of this work, or be avoidant of committed growth. What do you see within your role as the executive director to address this?
Yeah, it's a great question. And again, it's a very practical question that I've thought about a lot, and that a group of us have been actually working on specifically to figure out what some solutions might be and to understand what can create that dynamic, what it's really about, to inform some of the possible solutions. So, I would just start by saying that because our agency's mission and vision and values strongly align with health equity And we have a county policy on being an anti-racist organization. And we understand that racial equity is critical to being able to address health equity. It suggests that we all have to be in it to some degree. Now, why isn't it just program people as opposed to folks who aren't working out in the community? Because our manifestation of values infuses our agency inside and out. And we see that replication of inequities that we see out in the community. We see those same kinds of patterns inside too. And that's not unique to Boulder County. That is all over the United States particularly, but also the world. And so if we don't have a shared vision of how we as individuals show up with each other, and if we're not reinforcing practices that are advancing health and racial equity in our daily interactions, it's very hard to expect that we're going to get it right when we go into the community. And we're also ignoring the fact that we do impact each other when we work together. So the practical response to that is to say, okay, then to some degree, we all need to be on our journey, right? How do you do that in an agency that's really big with a lot of diverse people who are, as the question states, are coming at it different positions in their lives, from different experiences, with their own viewpoints. And one of the things that we have tried to do is recognize that, you know, the county is doing a lot of work in developing staff that kind of have bought into the work, that kind of have bought into the understanding of what the work is in the racial equity space, which leaves aside health equity more broadly in terms of our programmatic work, as well as attending to how do we create a bigger tent so that everybody values this work. And so one of the things that we've been talking about in HEC is really looking at learning and growth as a particular goal in our agency, and understanding that we need to be able to have offerings and safe spaces for people that are in lots of different spaces. So breaking it up into a couple of different cohorts. So an early group that really is, this is not my thing. I don't know what this is about. I don't feel safe going to conversations where you're expected to immediately identify your racial identity. Okay, that's where you are. Let's create a space where people get to ask questions that they feel like might be dumb questions or make mistakes, and not have repercussions, but have guidance and coaching and mentoring and folks that will support them to explore those ideas and to be able to ask questions that they might feel embarrassed in other contexts to ask. That would be what I would call a standard threshold. Some introductory courses, some conversations in a safe space where people can go and ask questions and learn. Then we also have the component of, okay, that's great. So you have an idea of what this work is. How do you translate it into action? How do you translate it into your programmatic work? How do you practice it at work? How do you show up with the behaviors that the agency expects? How do you learn how to correct mistakes in a graceful way and move on and do better next time? That practicing space. And then also having a group of folks who are really learning how to be mentors and leaders across the agency in this space. So that, I mean, we've got some folks that have amazing capacity to do racial equity work and health equity work. And how do we elevate that work and give them a platform to be able to kind of spread the work? Now, as an executive director, if I were to get this position, my job is to champion the work and to recognize that a lot of times I need to get out of the way of the work. I need to make sure that it is supported, that the resources are there, that the connections and relationships are there, that it's functioning well, that we're being effective in the space and adapting when we need to. But I also believe that the power of this work comes from the work coming up from inside the agency. And so my job would be to really make sure that this is able to happen. And that's a lot of what I've been doing over the last year when we did the HEC refresh, to really say, you know what, the HEC isn't functioning in the way that we had envisioned. How do we revise that? And so doing some of that structural work, some of that visioning work with a small team of folks, using that to really redefine what the role of the health and racial equity manager was, to write that job description in a different way, to give it more power, to give it more independence, and then to really, onboard that person, but also to step back and let the work be the work of our agency staff. In our HEC now, we have just resituated the membership, which includes folks working on 5 different work groups: learning and growth, organizational culture, policies, procedures, and practices, community engagement, and talent acquisition, retention, and cultural and career advancement. That hits a lot of work across our agency. And the representation is now 28 folks from across our agency. So 10% of our staff, over 45% of whom are BIPOC or LGBTQ identifying, and over 35% of whom are non-supervisors. And creating that architecture and then making sure that those folks have the resources and the leadership guidance from our health and racial equity manager, and making sure that that person has the support that they need, is really where the power of this work is going to start to come to fruition.
So next question is number 4. Over the last decade, public health has played an increasing role in responding to emergencies such as floods, fires, and the pandemic. What do you see as the roles and responsibilities of the executive director when public health emergencies arise?
I think this is a really important issue because we're going to see more and not less of these situations. And as we learned in the pandemic response, sometimes the challenges are more than a small, dedicated, excellent team can manage themselves. I think that there are a few things that are really important for the executive director to be responsible for. One is making sure that we have a plan that makes sense. The challenge of our emergencies is diverse, and the responses have to be diverse. We have to have an awareness of what different kinds of emergencies are demanding of us as a public health staff. We have to have an understanding of our partnerships and how we connect with community volunteers. Luckily, that's a lot of technical work that we have an excellent team in place that is, in fact, now working on, is like, how do we reset our planning for emergency management? But they can't do it by themselves. They can't do it by themselves because they need to know that they have the structure and the resources in place to actually implement the plan when those moments happen. So they have to know that folks have been trained properly, that their resources have been invested to make sure that staff know what the expectations are. They have to know that when they need to call on staff, that there is the authority to do so because it's been written into their job descriptions that this is one of the expectations of the work. And staff have to know what might be asked of them and to be able to communicate, this is where I feel comfortable, this is where I don't, here's some of the limitations that I have, my work doesn't really set me up for doing this kind of work. Okay, let's talk about that. And that we have had those kinds of conversations that really goes to a deeper level of planning than just, 40 pages that sits on a shelf that tells you what to do, right? It's really about how do we implement the preparation itself. We have to know that staff have, that we have thought about how people are compensated when they are working in emergencies, not just in terms of financially, but in terms of giving people a break. I mean, we learned in the pandemic that we seriously burned people out, and we cannot do that again. That took a big toll on our staff morale, on exhaustion, on retention. It wasn't unique to Boulder County Public Health. It happened all over the country. 50% of the people working in public health have left in the last few years, but we can do better and we know how. But we've got to have some of that leadership level support and championing for getting it right in place before these things happen, knowing that they will increase in the future.
Okay. This next question has two parts. I will ask the first and seek your response before asking the second. We have a varied set of public health partners ranging across the political and spiritual belief spectrums. During the pandemic, some of our important partners had opposing views from public health and wanted to discontinue mitigation practices with their organizations. What has been your strategy to encourage partners to continue working with public health and reconsider mitigation activities?
Right. So, I think I can think of a couple of sectors where we saw this. The pandemic mitigation strategies created a huge impact for local businesses and for schools. And we asked a lot of our partners to stand with us in those spaces and to listen to us with authority, sometimes with the authority of a public health order, but often in a collaborative, cooperative space too. We worked to try to meet their needs, to recognize the stresses that were being put on them and created for them, to recognize that it wasn't just our public health staff that was really besting it day in and day out, but that there were a lot of folks in the community that were hurting. Our strategy for a lot of the pandemic was to go to the data, to go to the science as much as we could, often recognizing that we didn't have all the data we needed. We didn't have all of the preparatory investments needed to be able to respond to that emergency. A significant part of our trust with the community, including the heads of the Chamber of Commerce, was really built in relationship and engagement. And at the same time, I know that there are a lot of folks that are still frustrated about things that happened during the pandemic. And I would say that in hindsight, I think, how many pandemics have we gone through in our lifetime, right? So how many opportunities have we had to learn and get it right? Well, I think we learned a lot in this pandemic about ways that we would want to shift our response next time. And I think a piece of that really has to do with something that I'm seeing more and more in our challenges in public health, which is recognizing the complexity of needs of our community in spaces. And so the same kinds of needs that we saw in the pandemic but we need kids in school. It's bad for their mental health. It's hard on the teachers. It's creating its own burnout cycles, all of those things. We've got to take a wider range of needs into consideration. And even if we don't change what we're doing in response to that consideration, we need to be able to demonstrate that we are hearing people and explain why we're making decisions the way we are. And I'll give you a different example if the pandemic example doesn't make you happy. The conversation about meth in our community right now is extremely divisive. It is connected to a really complex web of challenges that we are seeing in our society that go way beyond public health. We will not solve that problem by ourselves. We are going to be working in MBH space generally with a whole slew of community partners, and we have to really be ready to invest in trust and relationship rebuilding and strengthening in those spaces. I think Boulder County Public Health has very strong community relationships, and I think there's more that we can do to be good partners in this space so that we are really working collectively on issues together.
Okay, so let me ask you the follow-up to that. In these types of situations, how did you support your staff in working with partners whose views and beliefs may run counter to effective public health practices?
Well, so I'm going to pick on you and our team that worked with the schools, right? Partly because that team was in a very difficult circumstance where they were not going to please everyone. And they did a really magnificent job of taking the time to talk with our school partners, to work on solutions that were mutually beneficial, that still accomplished our goals, that created less havoc for the schools. And we know that there were some very contentious conversations in that space. I know public health directors that were fired because of their relationships with the schools. Part of what we tried to do in leadership to support our staff, when they were getting, a lot of heat from the school districts, was to make sure that they knew we had their backs, that we were talking with the superintendents on a regular basis, that we were accompanying them to meetings when they felt like they needed it. Sometimes presenting information to take some of the heat, and providing follow-up conversations when things weren't going well. That is, a strategy that I think is important for leadership to demonstrate consistently that they have staff's back, that they can be a stand-in for taking the heat when we're having difficult public conversations if staff aren't comfortable in that space, and it's okay. And we want to continue to have really strong relationships with our partners and recognize that their needs are sometimes different from ours in public health. And how do we do our best to meet everybody's needs? Because the reality is, when we impact kids' mental and behavioral health in schools, that's a public health impact too. When our school teachers get burned out, that's a public health impact. When small businesses close in our community, that's a public health impact. And so we cannot have super narrow understandings of what public health impact is in specific conversations. We have to be holistic because that's what public health does. We recognize that a wide range of social determinants of health impact your health. And it's our job, not like the healthcare system, it's our job to make sure that we are figuring out how do we balance that for the benefit of the community, keeping in mind who is going to be most impacted and always holding up our communities that are most marginalized, most oppressed, that need the support.
Okay, so now we'll transition out to our staff. Whoever has question 6, please introduce yourself, identify your pronouns and your title.
Marcela Shenes, she, her, hers, bilingual admin lead from immunization program. What's the most difficult but accurate feedback you've received at work? How did you respond and what happened as a result?
Oh, wow. This is a hard question to come into an answer on this spot. Not because there hasn't been an instance. Let me think for a second. I'm going to mention something that's a little bit vulnerable because I feel like I'm still working on it. Which is, I'm aware that sometimes I can be a little intense. I own that. And I also am cognizant that in balancing that, I really respect staff's viewpoint. I work really hard to listen to what they're telling me, to incorporate it. Sometimes I can feel a bit micromanagey. I will say in the context of working at BCPH, I think part of that is a factor of just trying to learn the organization. I never received like a full onboarding when I started here. I was kind of thrown into the enforcement group with Wayne Drager and appreciated that, learned a lot in that space, but didn't necessarily get a full experience of the agency. And I continued to find myself having to ask questions. And sometimes that feels maybe like I'm meddling too much. And maybe I am, and I have to think about that. But what I think I'm trying to do is I'm trying to understand this agency. I had a conversation that took 3 days over email with a team the other day, trying to get a response back to a commissioner because it was a space I'd never had a conversation about. And I had to learn what was happening here. What are our responsibilities here? What are the tensions? Is this something we've ever worked on? What would need to happen for us to be able to do this kind of work? I had to get all of that information, and that can feel intrusive sometimes. And what I'm really trying to do in the agency right now is, and what I would continue to try to do if I were selected as the executive director, is to really help all of us come together with a unified vision of what our work is and what we're trying to achieve. Because when you have that, you can let go of a lot. When you have a unified vision and folks understand what their role is in that vision, you don't need to go deep anymore. The executive director can focus more on other things that aren't being attended to and know that we still have a pathway for really using our very scarce resources in the most effective way possible without that kind of feeling like there's dipping too deep into the agency all the time. So that's something I continue to work on, is that touch point. Recognizing that, I think I have my own rationalization and justification for it, but whether that's felt by others, whether there's a sense to it, whether there's an exit strategy from it that helps to relieve some of that tension later, I think is also something that I think a lot about.
All right, number 7. Carrie Middleton, Emergency Management Planner. She, her, hers. This question has a couple of sentences in the intro. We strive to support and hold a diverse workplace. There are many indicators that may represent disability or lack of racial, cultural, or identity diversity. For example, once hired on, public health does not currently track ongoing diversity goals to monitor if we are visibly doing the right thing by our employees to address equity issues. Here's the actual question. From what you know about Boulder County and this public health department you may lead, can you verbalize a measurable, time-bound goal for workplace equity in our department?
Yes.
Of course, you wanted to expand.
Thank you for the question. It's a deep into the weeds question, but I very much appreciate why it's asked, which has to do with, we can talk about equity till the sun sets. And if we don't have a way to be accountable, then how do we know if we're getting closer? How do we know if we're taking the right steps? How do we know if anything's changing? This question is specifically about workplace equity, and which is ironic because, not ironic, serendipitous because actually our health and racial equity manager and I were on a focus group conversation with the National Association of City and County Health Officials about how do you advance workplace equity within the last few days. And there are a number of things that are happening now that are beginning to put the pieces in place for us to have such an accountability system. Having a body like the Health Equity Coordinating Committee was a necessary first step, but is not sufficient. Having a health and racial equity strategic priority that undergirds all of our work across the agency and will be part of our new strategic plan is a necessary but not sufficient part of the work. Having those tracking systems and answers to what do you do with the information and those opportunities to take that monitoring piece and turn it into a learning piece about what is this telling us about how we need to be, what we're getting right and what we're not there yet on, is an important part of the work. So this is all kind of the scaffolding, the architecture behind it. A measurable time-bound goal for workplace equity in our department. I think that staff surveys are an important piece of this, but I think staff surveys have to be careful not to get into averages where you kind of amorphize the data, but that you're taking into account the different experiences of different kinds of staff in the agency. And there's a tension there because even though we have a couple hundred folks in our agency, when you start disaggregating the data, it gets complex about anonymity, and we do want to protect people. So I think that we have to find a lot of different kinds of solutions to gathering the right data. A measurable time-bound goal. I am stalling a little bit because I think that this is an important question, and I also don't necessarily have what I think is the right answer to it, because I think that the staff should be involved in really defining what are our workplace equity indicators and goals. And that's part of what will be happening as we build out the health and racial equity strategic priorities. But, you know, you can take anything from a very kind of transactional goal of we want X% of staff to be BIPOC by 2025. Or you can take something that's a little bit more adaptive and say, X% of staff feel like their suggestions are heard in the agency. And that's an easy question to ask and a really hard question to understand what the data is going to tell you. And so I'm just a little bit cautious about saying, you know, we can have metrics and measures and we should have them and we should have that monitoring component, but the work is going to come from frequently revisiting this information and figuring out what are we learning about what's working and not working.
Number 8.
Alicia Kane, she, her. I'm the Family Health Nurse Services Coordinator. So this question has 2 parts. I will ask both. Please answer each separately. I can go back to re-ask if needed. How do you define community? What do you see as the public health department's role with priority populations in building community?
Well, this is a great question. I think you'll get a different answer from different folks on different days. when I think about defining community in the context of public health work, what I think about is the part of the community that's missing. And so it's almost kind of this negative question, right? It's not who is visible in the community. It's not what voices already have a great platform. It's not what is the dominant culture saying. It's where's the invisibility? What are the questions that aren't being asked? Who are the people that aren't being asked? What do we need to seek that's going to help us get to the things that we're not doing right, or we haven't successfully managed, or we want to go deeper on? And that's a tricky thing, right? It's like to look at the negative, the space, the gap, and to say, how do we get to that? To even identify what that gap is. And so I think it's really important that we have structures and processes in place that allow us to intentionally make space for different voices, because that's the only way that we will start to be able to hear those voices. We can't hear them. We can't even figure out what we're supposed to be doing unless we are being intentional about that work. So when I think about how do you define community? The community is, I mean, we are a public health agency. We serve the entire county. We serve everyone in the county. We serve individuals, families, private sector, partners, all kinds of folks. But what are we really talking about when we talk about where do we need to do better? We're talking about how do we as government respond and undo some of the historical oppressive practices, the ignoring of populations, the inability or unwillingness to engage in hard conversations and hard areas of work. How do we have the right talking partners for that work? And I think part of the answer to that is that we have to be working with community-based organizations that are not just service providing, not just nonprofits, but that are about representation and voice. How do we even identify the wealth of community organizations that do that kind of work? Because I know that they are here and we engage with a lot of them, and we don't engage with all of them, and maybe we don't need to engage with all of them, but I don't even think we have an inventory of who they are. And I definitely don't think that we've mapped the opportunities that we're missing for human development by not having those conversations or not having an intentional approach to how we work with community in that sense. It's one of the reasons why I think that community engagement and moving closer to power sharing with community is critical for undoing some of the harmful practices that government has historically impacted the community with. And we're not going to get better until we really have protected spaces to have those conversations where people feel like they can start to build trust with us.
So we have about 10 minutes left and 3 questions. So we'll try to pace it so we can get all 3. So number 9.
I'm 9. I'm Soda Sonora. I'm one of the nurses in CDL. As the executive director, where do you see your role in championing and progressing social justice movements such as police brutality, anti-trans legislation, reproductive rights, and climate change?
Oh, good, an easy question. Yeah, this is the conversation that I am having with a group of folks that I talk to nationally right now. So I'm part of the National Association of County and City Health Officials work group on health equity and social justice. And one of the conversations that we are having very intentionally in that space right now is how far can public health go right now, given the political dynamics that we have in this country and in our communities? And how do we maintain trust with the community and lead with not just our values, because I think part of what's critically important to remember in this space is that these aren't values just because we think they're a good idea. These are values that are predicated on what works to improve public health. Exclusion and ostracizing trans kids has a horrible impact on them and their families. And we are seeing that all over the country. And it is undermining our ability as a nation and as communities to advance public health, mental and behavioral health, opportunities in life, support systems that we know are critical to development and to being able to thrive in life. Recently, our health and racial equity manager and I were at a screening of a film about not quite police brutality, but racial abuse by the police department, contemporary in Boulder County. And it was screened in a venue with a question and answer with the producer that you would think would produce a really fruitful discussion. And what we saw was a community that was not ready to have that conversation, that was not trained in how you have that conversation in a productive way, that was having the conversation in a way that was really offensive and harming the Black director of the film. And it was embarrassing that our community showed up that way. And so we are working now to bring that director to public health to push the reset button. She said afterwards that she would never do a screening again with the public. It was awful. And we said, you know what, we have to get this right. And we don't want you to be harmed. And we want to model the behavior of what a healthy, productive conversation in this space about racial equity looks like. We have staff that can lead the conversation. We have staff that can learn from the conversation in a way that can be moderated. We can model this behavior, and this would be really good for her and for us, and frankly, for the community to see. And so I think it's critical that public health is always willing to engage in modeling the behavior, linking the issues to the data, and charting a positive path forward for the community.
We have time for one more question, so we'll do number 10.
Hi, my name is Dahlia and I'm she, hers. And I'm the administrative specialist for the Strategic Initiatives Branch. Question 10, have you ever received feedback from a subordinate or peer when your behavior caused harm? Provide an example on how you responded.
Yes, I have. And as crushing and cringy as it is to get that kind of feedback, it's really important. It's really important. It's important that you have enough trust with your staff that they feel like they can say those things to you. No one person is perfect, but I think that part of what we are charged with is improving, getting better and getting smarter and understanding how we impact people. And sometimes it might be about racial equity, and sometimes it's about personality differences, and sometimes it's just, wow, you are way too in your head and you had no idea how you were coming across right there. And so, we've got to not be defensive, right? We've got to say, ooh, I'm sorry. I didn't realize that. I have had that experience where there was a discussion that was had, and someone had presented something in a meeting, and afterwards, we kind of circled back and talked about kind of what happened in that conversation. And, I was in my headspace. I was like off and running. I'm thinking this and this, and, maybe it felt like this, and what could we do about this? And the poor person on the other side of the phone was just like listening, right? And that should have been my first warning, right? You're talking too much. Listen more. Ask. How did it feel for you? What was your perception? What do you think we should do? And a while after the conversation, the person said, that didn't feel good. And so we had a conversation about it. And I understood a lot better how I had come across, the fact that I get in my headspace sometimes too much, and I need to slow down and just be in relationship and listen, and what I needed to do differently next time. And it's kind of my approach. Nobody likes to make mistakes, but for leadership particularly, it's critical that those kind of conversations can happen, or you can't see shifts. You can't see empowering staff. You can't see demonstrations of respect that feel respectful. You can think you're being respectful, but if you're not getting that feedback, you don't really know. And we're really focused on how do we impact each other. It's not just what was your intentions, what was your impact. And I think that's a really, it's why leadership should constantly be humbling. Not because you're constantly making mistakes, but because that feedback loop is there.
Thanks very much. So that wraps up all of our questions for this round. So we'll be a little bit of time. So if you want to go out into the lobby, you can have a little bit of chat with Lexi, mingle a little bit, ask her some more questions if you want to. You have anything you want to wrap with?
No, this is an amazing staff, and not to be too much of a suck up, but the executive director position is important. It's important, but it doesn't make the agency.
Thank you very much. I am the Director of Admin Finance and I use she, her pronouns. We received over 50 questions from staff. We will be asking 11 today with the possibility of 3 more based on time. The questions will focus on leadership, community engagement, public health workforce, evidence-based data science considerations, health equity, and workplace culture expectations. To keep on track, we suggest pacing the responses at 3 to 5 minutes per question, and we've provided a copy to you for easy viewing. Amanda will also have a cue card, so she'll help you along if you get to that 5-minute period. I will ask some questions and then staff in the audience will ask questions. Please remember to introduce yourself, your pronouns, and your title. Just a couple gentle reminders. We are conducting a hybrid town hall, so we've got individuals here and then we also have individuals viewing. The mic is still hot. So if you are chatting or you have any other items, everybody will pick it up. So please exit into the hallway if you need to. And most importantly, if you came in with some bias towards a candidate, please remember to set aside any implicit bias and listen openly and with intent to what our candidate has to share with us today. Okay, so we'll go ahead and get started. Gary, can you please introduce yourself and briefly tell us about what motivated you to apply for this role?
Yes, thank you. Well, I guess it is afternoon, and good afternoon to everybody. It's good to see all of you, and I hope to get to know you here a little bit today and have a nice conversation. Gary Cox, he, him, and basically public health is my passion, and local public health in particular is my passion. And I've been the director of a county health department, 2 different county health departments for a total of about 25 years. And we did some things I think that were really forward thinking in those roles and to really make a big impact on the community in a positive way. And so I've had some experience and expertise. What do you bring to the table? I think what I bring to the table is experience and success in really working with 2 county health departments. I've also bring experience from the national level, the state level, and the local level. At the national level, I was privileged to serve as sure many of you are familiar with NACHO, the National Association of County and City Health Officials. And they're the group in Washington, D.C. that represents the 2,800 local health departments, including this one, in the United States in Washington, D.C. And I was on their board for 10 years. And so I had the opportunity to really learn a lot more about public health and be exposed to a lot of different people from different cultures, from divergent viewpoints over the years in that role. I visited a lot of health departments around the country in that role. Gosh, all the way from New York City, and who has a budget bigger than CDC's budget, to Los Angeles, to little bitty 2-person health departments in Connecticut, and maybe 5 people down in the panhandle of Texas. And so I learned a lot from visiting these health departments. And here's what I can say about it. If you've seen one health department, you've seen one health department. So my friend Pat Libby used to be the executive director of NACHO. That was one of his favorite sayings. There are commonalities in local public health departments. However, everyone's different. Every health department is different. Every community is different. And so we have to respect those differences. What was the second part of that? I'm sorry.
Yeah, what inspired you or motivated you to apply for this role?
Well, gosh, I've led all 3 health departments in Oklahoma, Tulsa, Oklahoma City, and the state. And then I was the associate dean at the College of Public Health at the University of Oklahoma and a professor there. And I So in other words, I kind of done the Oklahoma thing. My family, we've always really enjoyed Colorado. Real impressed with this department. It's a good department, a very good department. It's a good community. I mean, I'm looking on the outside looking in. It seems like the community is supportive of public health by and large. You've got the University of Colorado here, so you've got a good pipeline for hiring people here at the department. And so, local public health is my passion. I said, let's see if there's an opportunity to go to Boulder County and see if we can continue the success that we've had in Tulsa and in Oklahoma City. I kind of miss that. It's just my passion. I think helping people. I know the reason you're in this business is because you want to help people. And so I think that's why we're all here, making a big difference.
Thank you. So as you can tell, since we are holding the hybrid town hall, the vast majority of public health staff have been working hybrid or fully remote since March 2020 at the start of the pandemic. What are your sentiments regarding remote and hybrid work environments?
Well, we know during COVID, everything changed. And of course, there was a lot of hybrid work. Obviously, if you're a first responder, you've got to be in the field to come to work. You can't do that remotely. So I think part of it depends on the position. Part of it depends on what works for the staff. But I think the other consideration is we have to remember why we're here. We're here to serve the public, and we're here to work with the public to improve health, work with the public to protect health and promote good health. And so I think that has to be our ultimate guide for how we do our work here. And that is staff input, what's good for the community, what's most effective. I think, hybrid, we learned during COVID, you can do a lot of things hybrid. I've done CDC grand rounds and other things throughout that we did, virtually, and certainly it works. I think the thing that we might miss sometimes is that interaction among staff, getting to know the camaraderie of the staff and having that camaraderie as we do our work. So I mean, it's an open question. I think it's just something that you have to discuss and say what works best for the staff, what works best for the community, and what works best for the people that we serve.
Gary, I have a slight follow-up to that one. What role do you think the physical office should now play in the workday?
The central office staff.
Any actual physical office space?
Oh, so in other words, should we have a?
Yeah, let me ask it a different way.
Yeah.
So thinking about the physical office space, what role do you think that the physical office should now play in a workday?
Yeah. Well, there again, I think it depends on the roles and it depends on what the community need is. But obviously, I know some businesses have a smaller footprint in the office than what they had before. I can give you one example in Oklahoma City, the Dell, their parking lot is empty, practically empty. But certainly, it would seem to me that the ideal situation would perhaps have some flexibility there, but at the same time to be in the office some of the time so that you can work as a team and work collaboratively together and maintain that camaraderie. So I think, one of the things that's important, and I know it's been my experience of what staff want. Number one, they want to be listened to, right? Number two, they want to be connected. They want to be connected to each other, and they want to be connected to the community. They want transparent communications with executive director, with leadership team, management team. They want opportunity for professional development. And I say the opportunity for professional advancement and to be valued and to be inclusive, so that everyone feels like that they have a work home here.
Next question. As the executive director, you will need to make difficult and unpopular decisions at times. Can you tell us about a time you made a decision as a leader that was unpopular with staff? When answering this question, please identify what did you consider in your decision? Did you make any mistakes? And if so, what did you learn? And how did you engage and stay connected with staff?
That's a good question. You know, there are some times when you have to make a difficult decision. Trying to think of something in particular. You know, what we tried to do is we tried to have a transparent communication so that when decisions are made, you know, number one, the staff has input as many times as you can. And that those are communicated clearly, working with the staff. And then hopefully that the leadership team will also pass those messages down and receive input back. I think probably one of the things that we probably have done in the past sometime is when we had a program and when we went through the strategic planning process, and it was determined that that program was being served by another agency or by someone else. And then our strategic plan called for something of a higher priority that's going to positively impact more people. And so we decided, the board, management, and the staff, to maybe that we could put our emphasis somewhere else and not do that program any longer, as long as that program was covered. And so that has happened from time to time. And obviously what you try to do there, you know, some staff don't like change, and that's understandable. But of course, change is a part of life, but you want it to be positive change. And so I think, you know, what you really are looking at is how to make that positive change. And then you take that to staff and say, well, could you shift your emphasis over to another program that the board and our strategic plan says is going to impact more people in a positive way. And so you've got to stay, you have to communicate. I like to communicate with staff. I'm not an executive director that's going to sit in the office. I can tell you that. I'm going to be out around the department, around the facilities, and getting to know you, forming relationships. And so, you know, basically, the way I look at it, relationships are primary, everything else is secondary. And so we want good relationships, and I want to get to know the staff. I'm very approachable. I have an open door policy. I'm a pretty friendly guy, you know, how are you doing, visiting? And I tend to go around to all the programs and ask how things are going and try to get to know the staff. So that they feel that we can build a trusting relationship. Communication is very important. Gosh, I've held town halls like this, I mean, with a whole staff though. Many of them, particularly if you're doing a new program or new emphasis or something like that. I've done quarterly staff meetings, and then, you know, you want to try to recognize your staff for good work and for both for time and service and for the good work that they're done. They have team awards and things of that nature. And communicate in writing, and then, you know, work with your leadership team to double down that communication as well. And I just say, communicate. And so, I mean, there have been some times, some things that we've held staff meeting after staff meeting after staff meeting. And I think, I hope the staff's not bored, because I'm bored myself here, you know. So, you know, I think, but you can't communicate too much. And just try to, I mean, keep your eye on why we're here. We have a mission. We have a mission to help people. And we got to keep our eye on that mission. And we can't just dwell within our own selves and our own job. We're all connected together. And everybody has a job to do. But I've got an open door policy, stop in, say hi, how things going. I'm good with that. And so, and you know, I'll put it this way too. I'm approachable. I started out as an entry level environmental worker in the field. So I started out at the entry level, as low as you could start in public health. And you know, I worked hard, rolled up my sleeves. I tried to improve myself again and again and again. I got training for myself. And through hard work and some luck and some good mentoring and some good, you know, good mentoring, I was able to progress up. But here's the thing. Here's the thing. You know, every one of you can do the same thing. You can all do the same thing. Everybody can be a leader. And I expect everybody would be a leader in your own right. And yeah, can you start as an entry level person who doesn't have the experience or training and go right up to the executive director level or the division director level or to be the president of NACHO? No, that's not how it works. You know, you start here and you build, then you build a platform there, a stair. You improve yourself, then you go to the next level and then you build and develop new skills there and you just keep building. So I can tell you, if I can do it, anybody sitting in this room could do the same thing. You can advance, you can be a leader in public health, and you can make significant progress and contributions to public health over your career. It's a great career.
Okay, so Gary, this next question is a little bit longer.
Okay.
In public health, our mission and vision strongly center around health equity and promoting our staff encompass and represent this through a variety of approaches. We understand each person is in a different part of their journey and we respect and support this. We are also aware that sometimes staff can initially be hesitant to participate, continuously abstain from some of this work, or be avoidant of committed growth. What do you see within your role as the executive director to address this?
Good question. Health equity is something that I believe in. It's my core belief. I'll give you a couple of examples of how we've done it throughout in the department. But everybody matters. Every person matters within the staff, the divergent, different viewpoints, different cultures, different life experiences, they all matter because we operate on a team basis and we all have to operate together as a department. And we can be made much better by recognizing and inviting diverse groups to be an integral part of what we do. And so as a matter of principle, I agree with it. I put it into practice over years in my career. So it's more than talk. It's stuff that I've followed through with and done. And I'll just say, I was on the board of NACHO for 10 years. We had these discussions on health equity, social justice, inclusion. We had these discussions 15, 20 years ago. It's not something that's new. It's got maybe a little, it's progressed and it's different. But these are things that we talked about as a NACHO board 20 years ago. And we prioritized it. We believed it. We learned about it. We grew from it. As things changed. It's important. It's important. It's critical. Everybody has to be included or we can't not be effective. We cannot be effective. Now, I'll give you an example. Oh yeah, it's just a bunch of words, Gary. A bunch of words. Now, here's what we did. Oklahoma City. At the Oklahoma City County Health Department. I was the director there 10 years. So what we did is we did zip code by zip code analysis of our health assessment, right? We called it a wellness score. It was a kind of a combining of metrics that we used. And so what we found something that's pretty shocking. Here we're public health, right? Supposed to be improving health, working with our community, improve health, protect health. promote good health. What we found was shocking. What we found is the best health performing zip code and the most challenged health outcomes performing zip code, the best and the worst. Okay. The average lifespan difference between the most challenged and the very top is 14 years of lifespan difference, 14 years. And I can tell you, they were in the communities of color, and the zip codes were very clearly pointed out that data. So what do we do? I mean, data is no good if you don't do something with it, right? So what do? We worked with the board, we worked with management, worked with the staff. We said, well, here's what we're going to do. There's no services in this worst performing zip code, very little services, right? A void of services. We're going to go in, we bought 50 acres in that zip code, and we built the health and wellness campus. In that campus, we had all of our services, the preventive services, the wellness services. We brought in the College of Medicine, we provide primary care, or you could partner with FQHC or whoever. We developed behavioral health services there. Guess what? We had a 1 mile walking trail around there because what? Physical activity is important, right? We worked with the Extension Service, and they located there. So they did a lot of food, nutrition, education, things of that nature. And we had community gardens. So we had community gardens there, walking trails, exercise stations. Then we partnered with the professional soccer team. What part did they have? They brought in and they built a practice field there for the professional soccer team. They coach kids and they bring in kids and coach kids and then soccer leagues and all this for physical activity for kids. And so, that was really, and we put our the first dollar that we spent, available money, on building that campus in the most challenged zip code in the county. Most challenged. And so put your money where your priorities are. And you put your money in your areas of greatest need. Why? Two things. Number one, it's the right thing to do. And number two, if you want a big increase in health outcome improvement, you have to go there first. I could give you many other examples of that, of actual lives saved, but maybe we have time to get into that.
Okay. So Gary, over the last decade, public health has played an increasing role in responding to emergencies such as floods, fires, and the pandemic. What do you see as the roles and responsibilities of the executive director when public health emergencies arise?
Well, we all, and anybody that's been through COVID, it was tough. I know you knew it was tough. I dealt with it as well. And I've dealt with public health emergencies. I've dealt with floods, fires, wildfires, earthquakes, you name it, and tornadoes, big tornadoes in Oklahoma. The biggest tornado in history, recorded history, was just west of where we live. It was 2.5 mile wide tornado, 300-mile winds. And as a matter of fact, just 3 weeks ago, we had a wildfire. It was just 2 miles north of where we live that burned 82 houses and buildings. And so it's, it seems like we're having more and more of these public health emergencies. And of course, these are the things that we would deal with most often: floods, tornadoes, wildfires, things of those natures. And then, we're going to have the disease of the day, right? We're going to have the epidemic of the day, whether that's SARS or H1N1 or of course, the pandemic of the century, COVID-19, which was horrible. So I've led efforts to respond to all of those. Very familiar with it. Very familiar with the incident command system and DIMS. Had a lot of experience in that area. So obviously, as an executive director, you're going to rely on your experts in public health preparedness, all hazards preparedness, and all of that, right? You're going to rely on your staff and your leadership there, but ultimately you've got to be the leader. You have to be the leader. And of course, it's important too, the things that you all have been through, the Marshall Fire with the pandemic and all of that, you know, staff resilience. And I mean, you can almost go into post-traumatic stress. And so you have to be aware of that, aware of how it's affected the staff, aware of some of the people that don't respect what you've done. And so be supportive of that as well. Be supportive of the staff. And, you know, to me, here's the big thing. One of my big goals would be this. And I don't know, I'm looking from the outside in, so I don't know the situation of staff morale and all these other things. I've heard a bit here and there, but to me, one of the primary goals is to do what I did in Tulsa. Come in and assess the staff, talk to the staff, get to know the staff, and then go about making it one of my primary goals, getting this trust of the staff and making this department the most enticing place to work in Boulder County. Make this a great place to work. Maybe it already is. I know it has areas of greatness already. Maybe it's across the board, but we can always do better. But I know when I became the director in Tulsa, nobody wanted to work there. Staff morale was bad. Staff was burnt out. Didn't have a very good reputation in the community. And I said, you know, we're going to turn this around. We're going to work with the board, the leadership, and the staff. This is going to be a great place to work. And it's going to have that reputation in the community. And, you know, we did it. It happened. And you've got to have a little fun because we spend a lot of time work. So why not have some good times and fun and collegiality and you know, be good colleagues and supportive of each other because we're all on this big team. And so,
Great, thank you.
good.
So this question has two parts. I will ask the first and seek your response before asking the second. We have a varied set of public health partners ranging across the political and spiritual belief spectrums. During the pandemic, some of our important partners had opposing views from public health and wanted to discontinue mitigation practices with their organizations. What has been your strategy to encourage partners to continue working with public health and reconsider mitigation activities?
That's a good question. Well, yeah, particularly with the pandemic, excuse me. It was challenging. And, you know, it was challenging for partners too. And everybody didn't agree. So how do you do that? I think in the first instance, when you talk about public health preparedness and emergency preparedness, you start out with the idea of all hazards preparedness. Then you move to the idea of you build relationships first. So, you know, you've heard the saying, you don't want to, the first time you hand out business cards is in an emergency. You don't want to hand out your business cards and just be getting used to meeting someone and trying to develop a relationship when you develop emergency. So it's key to develop these relationships and these trusting relationships first. And then they're going to be more likely to, maybe they don't agree 100%, but at least understand our points of view and be more supportive of it. And, you know, maybe there's some areas, always look, I mean, it's about talking to different people, listening to people. What are their concerns? What are their concerns? We got to listen to them. And is there any common ground here? We may never totally agree. We may never totally agree. But you know what? At least we can listen to each other, be respectful of each other, and understand each other. And so I'll give you a good example. My first day on the job as a commissioner, one of the people in the office came in and said, "We got 300 people down in the parking lot that are having a demonstration." And it's getting kind of unruly down there. They want to see the commissioner. I said, well, and because the last commissioner wouldn't meet with them, right? Last commissioner wouldn't meet with them. I said, well, the governor's called me over his office today, and I can't meet with them today. But if they will be respectful, I'll get them on the calendar and we'll meet. So that message is relayed to them. Yeah, they kind of went home kind of unhappy. Well, in about 2 weeks, we scheduled a meeting. And I said, look, this is the ground rules. As long as you're respectful, I know that you're upset, but as long as you're respectful and we can have an adult conversation here and listen to each other, we'll have a meeting and we'll see if we can agree on some things. Well, so we did. I just let them talk, and they had, you know, they were angry and they expressed that anger, and I just listened. And then after they were through, I said, well, okay, what can we agree on? Well, we ended up, we had several things we could agree on. And so after that, we really had it was not a contentious relationship. Did we agree on everything? No, we didn't agree on everything. Matter of fact, we regulated that industry, but we did listen and had that open communication, which I think is important. But you got to have partners, and I think science. All of this has to be science based, and that's what we go on. But keep in mind too, science changes, right? I mean, gosh, look at COVID. From the first days of COVID back in February, March, and what we did, I could tell you, because I don't know if you knew it or not, but I was the health commissioner at the time when the first professional game in history was canceled. That was the Utah Jazz, Oklahoma City Thunder. That was a decision I didn't want to make. Folks, I can tell you, I didn't want to make it. But you know, we didn't know much about COVID at that point in time. But we knew that it was infectious and we knew that it could kill. We didn't know exactly how it was transmitted. A lot we didn't know about it. But I called, we tested the player. I called the governor up. The governor said, what do you recommend? I said, this could be a short career. I recommend we cancel the game. That seems like a no-brainer now, but believe me, on March 11th, 2020, it was not a no-brainer because no one had ever canceled a professional sports game in the history of this country for a health-related reason. And so we worked through that. I called the governor and he said, okay. He got the NBA commissioner, the owner of the team, the two teams on the line, and that's what happened. And those of you, if you've seen any of those, any of the news stories about that, that would resonate with you. So it's tough work, you know, but we build relationships, and we try to keep these partners in place to the best of our ability and do everything we can do. But there was an old general that once said this. He said, you have to work with an army of the willing. So you have to keep in mind, as much as you try, as much as we try, there are some people that will not see eye to eye and won't work with you. So you say, I'm sorry about that. We're going to see everything we can do to get you to work with us. But we're going to go forward with the partners that will work with us and we'll work together.
So I have a follow-up. I know we extended the time just a little bit on that question, but I'd like to give you an opportunity to answer.
Sure.
So in these types of situations, how did you support your staff in working with partners whose views and beliefs may run counter to effective public health practices?
Well, I think you support them by by being supportive, you know, by saying, you know, I understand this. I understand that we don't agree here, but let's take the high road and work with those that will work with us, and basically support the staff in those efforts, but realize and I guess reiterate to the staff that we're here to do a job. We have a mission, a job that we have to do. And so we have to keep that primary in our minds going forward. But do everything, support that we can for the staff. If you can, you know, anything of supportive activity, and try too to have a break in all this tension and everything and do something that's uplifting, that's fun for the staff, that the staff can get involved in, feel good about. And a lot of that depends on helping other people.
Thank you. So we're going to transition out to the audience now. So if you have question number 6, please go next and identify your name, pronouns, and your title.
My name is Cindy Campbell. My pronouns are she, her, and hers. I started here as a COVID-19 investigator. This year I've been a disease intervention specialist, and we're still doing some investigations. What's the most difficult but accurate feedback you've received at work? How did you respond, and what happened as a result?
Okay. Well, I think some of the feedback that I think I received from work that was difficult, but that was true, was that perhaps we had a very, I want to say, forward-thinking strategic plan, 5-year strategic plan with a lot of very ambitious goals. And my board, I worked for the board said, this is it, do it. And so I'm an action-oriented person. And we started and we got our management